afternoon, everyone. It's 3 o'clock and we're going to get started. Welcome to our discussion, Disability and Health in Context, the Dynamics of Care. This event was sponsored by the Disability Awareness Month Planning Subcommittee of the Siena Center for Social Justice Heritage Months Committee. Thank you to Elizabeth Mondrakia, Jacqueline Williams, Kimberly Geary, Jeannie Kimball, Andrea Morgante, Jennifer Scoro, the Dean's Office in the School of Arts and Sciences with the Center for Social and Ethical Concerns, Kathy Muscante, and the Siena Center for Social Justice, as well as the members of the Disability Awareness Month Planning Committee. Content warning for this particular webinar. We will be discussing ableism, experience with disability, medical-related experiences, including injuries related to trauma. This event will be recorded, but we'll stop at around 4 or 4:15 for a question and answer session that will not be recorded at the end. The recording of this event will be on the YouTube channel of the Molloy University Center for Social and Ethical Concerns. My name is Lisa Lumley. I am an instructor with the School of Nursing. I am, for those who need a description, I am a Caucasian, middle-aged female. I have long dark hair, and right now I'm wearing reading glasses. I'd like to introduce our three dynamic speakers. Our one speaker, Dr. Brian Bajzek, is an assistant professor of theology and religious studies at Molloy University. He holds a Ph.D. in theological studies from the University of Toronto and Regis College from 2018. His research investigates the interplay of otherness and similarity in theological anthropology, highlighting the importance of productive engagement between religion and society. His writing and teaching also explores the resources popular culture, especially horror movies, can provide, both critiquing and strengthening religious accounts of social justice. Dr. Bajzek has published in the Heathrop Journal, International Philosophical Quarterly, Theological Studies, and several edited volumes. He is currently revising his dissertation for publication in book form. Dr. Andrea Spatarella is a full-time assistant professor at Molloy University in the Barbara H. Hagan School of Nursing and Health Science. Dr. Spatarella teaches undergraduate courses in growth and development across the lifespan, pharmacology, and adult health too. She received her doctorate in nursing practice from George Washington University and a master's degree in nursing from Stony Brook University. She is an advanced practice registered nurse and is board certified as family nurse practitioner. She is a member of the Nurse Practitioner Association of Long Island and the Developmental Disabilities Nursing Association. She is the parent of an adult daughter with intellectual and developmental disabilities and served as a parent advocate in her local school district. Dr. Warren Whitaker has been working in the education field as a disabled scholar and a practitioner for the past 13 years. He uses critical frameworks in his research to examine educational leadership in K-12 and higher education institutions to promote equitable education experiences for disabled and multiple marginalized students. He has published journal articles, books, has served on the editorial board for the Journal of Post-Secondary Education and Disability and the Journal of Leadership and Instruction, peer-reviewed journal, has reviewed for and presented at national and international conferences. He has written a book series, co-author for Critical Leadership Praxis and Pedagogies. And Warren, Dr. Whitaker is also a University Council for Education Administration, Barbara Jackson Scholar alumni. I'd like to present our three esteemed speakers. So we are going to devote a certain amount of time for each of them, and we're going to manage this as a discussion. So if one of the speakers would like to begin. And if you have questions, you can certainly put those in the chat, and we'll reserve that for our question and answer session later.
Hi, good afternoon, everybody, and thank you for coming to this really exciting event. So my area of specialty expertise, so to speak, has to do with individuals with intellectual and/or developmental disabilities, referred to here as IDD. So just to provide a little background, intellectual disabilities and developmental disabilities are conditions that are characterized by significant limitations in both intellectual functioning, also called intelligence, and adaptive behavior. All of that originates before the age of 22. These conditions may affect day-to-day functioning, usually last throughout a person's lifetime. Some of those deficits in adaptive functioning can be in different domains. Conceptually, difficulties with language, with reading, writing, math, reasoning, knowledge, memory. Social domain, to do with empathy, social judgment, communication skills, the ability to follow rules, the ability to make and keep friends. And in the practical domain, where we have difficulties attaining independence with things such as personal care, job responsibilities, managing money, recreation, organizing school and task work. So there are actually about 16 million Americans with IDD, and they include some common conditions like autism, cerebral palsy, Down syndrome, attention deficit hyperactivity disorder, more rarer disorders such as Williams or Rett syndrome. And often these conditions overlap. For instance, when, let's say, an autistic person or someone with Down syndrome also has an intellectual disabilities. We also know that many of the causes are unknown. We never find out exactly why this person has this disability, but yet we must deal and, adjust to those different abilities and disabilities. So the American Association of Individuals with IDD stresses that we have to consider lots of factors. We have to consider the community environment typical for that individual, the intersection of linguistic diversity, cultural differences will all influence the way a person communicates, the way they move in their space, the way they behave. In addition, when we're engaging with individuals with IDD, it's really important to appreciate that an individual have strengths that coexist with their limitations, and that many of these individual life skills will improve when we employ appropriate personalized support, and it's over a sustained period. So we know that the disabilities rights movements that emerged during the 20th century really focused on eliminating institutional and physical barriers faced by individuals with disabilities. When we closed institutions such as Willowbrook and people with IDD became integrated into communities, it resulted actually in people with IDD living longer. Sounds like a good thing, right? Well, many of those individuals with IDD still face really significant barriers as health systems are really slow to catch up with those social changes. The fact is that people with IDD are the most medically underserved groups in the world, and they face significant health disparities not directly caused by their primary disability. So take it a step further, those disparities that we find in access and availability of appropriate care are really magnified if you live in a rural area or if you're a person with a disability and also a person of color. So that intersectionality is something that we really, must take into consideration, both when we're interacting with individuals with IDD and certainly for myself as a care provider, taking that into consideration when I am out there making suggestions, making recommendations, prescribing medications. So some of those barriers that we've seen among healthcare providers are implicit bias, stereotyping, misconceptions having to do with a disability, really not considering those strengths when you're looking at the person as a whole. Another obstacle that is, pretty obvious is something we call diagnostic overshadowing. And this happens when a person with IDD and very often with a communication deficit as well. And that person presents with either a psychiatric or a behavioral disturbance. So instead of looking for a physical cause that may be the reason for this person's behavior, it's automatically attributed to that person's developmental disability. So, individuals with developmental disabilities have the same and sometimes increased risk for chronic conditions, things like obesity, hypertension, heart disease, diabetes. And this is compounded when there's challenging behavior as well. And some of that challenging behavior can be pretty dramatic. Things like aggression, self-injury. It's often misdiagnosed as a behavioral or psychiatric disturbance when in fact there may be a true physical cause. So, I know about that personally. As Lisa shared, I have an adult daughter with significant IDD. And, over the years, I've had many instances where there was a lot of correction that had to be done with healthcare providers, a lot of, redirecting the way that visit is going to go. And speaking about that, only about 20% of medical students, when they're in medical school getting their basic training, 20% or less get any training at all on how to provide care for individuals with IDD. It is not required. It is not part of the curriculum in most medical schools. Those that have received training, it is minimal at best, maybe an hour. Some of the studies I looked at, the most training that was given was about 11 hours totally. So aside from the lack of familiarity with the unique characteristic that this person has, my thinking is that 15-minute time slot enough? By the time, my daughter decides to actually get on the scale or cooperate for her blood pressure, we've already chewed away at 10 minutes of the visit. The other parts of the study showed that more than 90% of healthcare providers reported they did not feel comfortable treating individuals with IDD. And many actually said they preferred not to. We do see a shift in this, though, going forward now. A lot of the younger practitioners are more apt to accept these individuals into their practice, which is good news. Just looking back not so long ago during COVID-19, the significant change that individuals with IDD had to interact with the healthcare system was pretty dreadful. Families such as myself, we kind of lost trust in the medical profession during COVID-19. Going to the ED with a patient, they were not permitted to have a support person, the person that could speak for them. They were isolated for months, either at home or in their residential setting. Care was not delivered in an equitable manner. And we found that having IDD was the strongest predictor, not only for COVID-19 infection, but the second strongest predictor for COVID-19 death. It's pretty impressive. So I will say it's not all bad news. There have been improvements in trust building. Telemedicine really helped for allowing, the sickest of those patients to be seen. If they need to be referred, they were. If they were less severe and they need to be kept in place, that was allowed to happen. So not staying on the negative, tone of this, I'm thinking about where can we do better? Where can health systems and practitioners like myself and those like me do better? Well, there are now many online courses for healthcare providers to familiarize themselves with those unique characteristics. Some medical schools and nursing schools now have rotations that actually take place where the student goes into the home of the person with IDD. And they really get the true picture of really what is that person's functioning? What are they like in their own environment? So some other ideas, since, I'm very familiar with the individual with minimal communication skills, some of the things that can be suggested to that caregiver, they sound really simple, but when put in place, they can make a tremendous difference, such like allowing additional time to exchange information, getting some kind of assessment of that person's ability to produce language and speech, and then model that level of language when you're speaking to them. Talking with somebody with a mild communication difficulty is very different than talking with a person with a moderate or severe communication difficulty. Generally, people have stronger receptive or understanding communication skills rather than expressive, but I also know many cases where a person can have very, elaborate expressive speech and really give the impression that their comprehension is, much better than it is. So it's really important to check the patient's understanding. We know that individuals with IDD have low health literacy. So it's really important to take that into consideration. So keeping in mind that the American with Disabilities Act and the Rehabilitation Act of 1973 actually require doctors and other healthcare providers to ensure that they have effective communication. So what does that involve? So that involves maybe having someone that can interpret some simple sign language. Maybe it means there's some auxiliary aids like a communication board, a picture board. If the patient has low vision, maybe they would need a braille device, maybe a hearing accessory device. So that is supposed to be done at every visit, and I can guarantee you it is not. Some other recommendations, for those of us interacting, for trying to communicate with that person, keep distractions to a minimum. Speak to the person. Even though they may have a support person with them, it's important that we speak directly to them using concrete language. Explain what is going to happen before we begin. Show them what you're going to do and why we're doing it. So we want everybody with IDD to have a voice in their care. That is really important. But there are times when it's difficult for that individual to make a decision alone. And that is where supportive decision-making comes into play. So that supported decision-making is an individual that is chosen by the person with IDD. It may be a friend, a family member, or even a professional to help them making decisions. It's critical to recognize that, we have to maintain patient rights, individual rights, and that helping them make those decisions are super important. So, I have a lot of other ideas and suggestions. I believe my time is probably near up, but I would welcome any other comments or contributions from anybody else on the panel or, even on the Zoom.
Thank you, Dr. Spatarella. Dr. Whitaker, Dr. Bajzek, would either of you like to go next?
Yeah, I can go. No problem with that. Yeah. Yeah, and following that, that was great info, and I think it's needed to understand that everyone does have needs, and we have to figure out the best ways to help them from their perspective and not the other way around. My name is Dr. Warren Whitaker. I'm in the School of Education, the EDD and Leadership for Diverse Learning Communities program. And my experience with this notion of disability is like twofold. I'll begin with a professional piece, and then I'll come back with more personal part. Professionally, like my research is research related to the post-secondary education experience of disabled students, understanding that from birth or pre-K to 12, if students are identified, there's a stringent process, stringent procedures and policies that may support them in their navigation of education. Once graduation comes, is whether it's 18 or 21, whatever, and if they do go onto a college campus, it changes as far as the responsibilities, the roles, and the structures and the policies. They move from the IDEA with strong federal policy to ADA, which it requires them to disclose disability, them to try to get services as well. So all of that and knowing the big changes in there, like in the differences, like that's what I really wanted to study. Reason why I was a school psychologist in Arizona for about 8 years, and I had worked with different students in middle school to high school. But I was really close to one student, and the student had finished his senior year, and he's off to college, going down to college, going to I think community college down in South Phoenix. And I was like, oh great, this and that. And then I saw the student at a store in the beginning of the fall, and he working at the store. And I was like, oh, okay, you're working, go to school. And he told me that, yeah, he was working because he didn't need that school anymore. And I was close to him. So I was like, no, let's talk a different day. So I met him out, then got like coffee or something, got him some donuts. And then we were talking, and he broke down. He was just like, I didn't know what I was doing. It wasn't like high school. Like I didn't know where to go to, and it was a struggle. And I was really caught off guard by it because I didn't understand back then. He was like, it's just a whole new thing. So I did my research on it, and I began to do more like studying into that. And like that was direction I wanted to go for my Ph.D., just in understanding that part, like his needs weren't being met on like the college campus, and he was able to do that. So that story kind of like sparked my interest in that journey in the research, the Ph.D. Fast forward, I was able to help him kind of navigate that, and he did graduate 5 years ago, so it was exciting. But that whole piece and professionally, like just like advocating for disabled students, like my life's advocating. That's what I did like most of my life. So I like that in research and everything, knowing that the world and the systems were not made for disabled people, and that ableism is real and alive, and just being able to do that part. Now it flipped to the personal side. A few years ago, I have 3 children, but like my oldest daughter, she had a crib, so like work was kind of going crazy too, but she had a crib and I needed to put it together because she was coming home soon. And I remember sitting down with like the directions and ready to like go. And I was like, okay, I'll put it together. And then it was like 7 hours later, and I was sitting there and it wasn't together. And through that frustration, some conversations, I kind of knew something was up, just from like things were happening at work, a lot of files and stuff, just things I was making mistakes, and it was just kind of all piling on a little bit. And even with that, so I was sitting with myself and just thinking about, man, like knowing like at a deficit driven, something's wrong, I need like something, but I don't want to do it. So I was battling with myself to get the support, not get the support, trying to call myself out, like you do this for these students and like you don't want to get the support and help. So I was like just going around and around. And my boss, Dr. Jinkoba at the time, like I think she saw what was going on. She didn't know about the crib and everything, but she saw what was going on, and she like brought me in office sometimes. She was just like, hey, like you think something may be up just about the way that you learn or the way that you do work. And she told me her story about this, going down that road, being diagnosed as disabled, and just how she moved from that. She was a superintendent at the time at the district. So I was like, yeah, I think something's up, whatever. So I got some support and some help and some encouragement from some people at my church, and then I did go to through that whole process, right? And I got identified as ADHD and attentive type and a nonverbal learning disability. And like hearing that from a different side of like the table, whether I'm saying and hearing that was just like next level, like, oh, what does this mean? And I had my medical eyes on, like, man, it's okay, so wrong, so you can't do this and you can't do that. Okay, so when you read, like, you may need this. And I had such a medical like deficit um to that. So it was like it's been like a marathon, like with that part and like working into that. So part of research that I do is like to make sure that I use identity first language. So I'll say disabled scholar, that I take back the words, the notion of taking that back from society. So I really am open with that part about it. Uh Trying to write from that and like trying to talk through that. Like with myself, it's just like a daily thing, but I've come a long way, I would say. And just like be open with it and disclosing. And I was like question about like disclosure, but I'm open to disclose. And I've seen that's been helpful. You know, that's been helpful for me, one. And I think sometimes it might make it easier for conversations too with others. But just that whole disclosure, but it's an everyday thing, you know, kind of look in the mirror like this is who I am. And I've reframed it to like this is how I see the world, right? And things like great and that part about it. Now the marathon part is with like the close friends and family, right? So I'm a family driven person, a lot of friends, close, like everybody thinks, I don't know. Some people think I'm cool, some people don't. But just that piece, right? Because when it became time for the close family and stuff, the intersections came in. I'm a black male. Sorry for those. Let me track back. I'm a black male. I'm on the screen. I have a Molloy, black Molloy polo on. My hair scruffy. I have kind of a goatee. A little bit of hair on top to shave, and have a blurred background. But and moving forward to when it came time to the conversation with the close family, like that's that intersection coming into play, especially with the race part. So it's saying that got invited disabled, and understanding like the Black experience. And my family, at first, especially like my parents and my older brother were like, nah, you don't want to do that. Like you don't want to do that. You don't want to say that. And why? Because them understanding the experience of Black people, Black males in general, like, okay, so you don't want to give society like another mark against you. Like society is really like deficit. You don't want to do that. So no, it's just them, it's just the man, it's all this, and everything like that. So those were hard conversations to have like over the years, like with them. But I kept adding and stuff and trying to open them up and to seeing like different angles of it. So it's been a work in progress, but I think I was able to break some things open last year with them seeing that, and that it's not a deficit, it's a different way of like seeing it. And some of the characteristics that I have, my I know my dad had it too. He's like, oh yeah, I used to be like that. He's like, I'm like that too, especially when it comes to this and that. So we're able to kind of find like new meaning in it. That's been helpful. Friends, friends definitely with the deficit orientation, like my nickname's, call me like Sap. Like, no, that's not you, Sap. That's like so and so. That's not you. That's so and so. And I think that's a piece within, invisible part of the being disabled too, is that they can't see it, so it's not doesn't exist. So I'm like, no, like that is me. Oh, you like this about me? That this is a part of me too. So I think that's kind of ongoing too. That one's still ongoing, but just like that piece and really like sharing that part. I've had like two friends come to me by themselves outside of like groups and stuff and just say like, look, I'm gonna, I think there's some depression with me. I'm not feeling well. I'm gonna go get, what do you think I should do to go get checked out? So I think there's some gains in it, but it's just like a ongoing process. So I think in general, like I said, it's a marathon. I am nothing of a runner, and I know it's 26 miles for a marathon, so I just keep going. I just say like this journey is just like you keep going with it, and understanding that part. And there's layers to it, like especially with the intersection piece, like there's layers to it. So there's racism and like systems, and ableism systems, and then it's like both. What do you do with that, right? And like part with me, if I walk in the room, you're gonna see the race first. Race is gonna be like prevalent first, and then disability. So I try to like incorporate both, and also like frame and do some research from that lens as well. But I think that's been my journey. Still like in talking and doing panel like this, did a couple of panels. I think it's been helpful, but I think just understanding like this has always been me, and maybe I have been able to compensate in other contexts. But just kind of allowing that piece of me to shine and not necessarily like hiding behind it. I put it on one of my Twitter handles, and I was like, oh wow, that's a big step, like a year and some change ago, just to like put it out there. So not really hyping about it and talking more about it and feel more comfortable. I think that's been really helpful. And I'll say like a piece in this part, like community is everything. And I think the stories that people have and just like the comfort that can be provided within like disabled spaces, I hope there's like more time for that and more people to come. And I think myself and just understanding representation, it goes a long way in the communities I'm in. Just like me disclosing, me having some knowledge on it, like, and helping individuals and parents and caregivers, like, not to see like it's the end or like deficit, like it's only the beginning, and like to really find some strengths into it. I think like that's been uber helpful. And it's just it's a work in progress, because there's like there's been years of like the system and the mechanistic thinking and deficit thinking around it. So I think it's just helpful with that. Even in the program I'm in, if students are writing about it, like we talk about it, and most of the time it's been students who've had some proximity to disability. I don't know if it's family, if it's friends, or like they work, but I also try to make sure that if you're gonna, be in those spaces and do the research, we have to speak from a place of power. So I think that's been also helpful. And then finally, I'll say one last thing. All of us, in anything we do, any organization we're in, that we can always look for ways to ensure that everything is has universal design, like in thinking, universal design for learning, like in thinking. What ways can it be accessible, multimodal, more ways of representation, more ways of like assessment, but how can we make everything accessible? I think that has to be the beginning, right? From, if you're doing a Zoom like this, closed captioning, like talking about what you look like. If you're doing like an announcement to the public, do we have something in sign language as well? Like capturing that part, like anything you can do. It's not necessarily like disability, but like for everyone can benefit from that. And there's a significant population of students and people who have not disclosed. It may not have gone through the process. It's like research backs it up. Whatever reasons people have, that hasn't happened. But in using UDL, we can make sure that it's as accessible as possible. It'll never be fully accessible, but you all want to strive to do that. So the more you like make it more rigid, the more you kind of create barriers. So I was saying, just keep that in mind. Anything I can do, how can we ensure that this is as accessible as possible? Thank you so much for your time.
Thank you, Dr. Whitaker. Dr. Bajzek, would you like to comment?
I would love to. So much of what was just said resonates with a lot of my own experiences, as I think will come up in a moment. So hello, everybody. For those of you that don't know me, I'm Brian Bajzek. I am currently in the process of moving offices, so apologies for what's behind me. Our department's moving. I am in the Theology and Religious Studies department here at Molloy, and this is about to swerve into an academic paper, because I am who I am, and I could talk for about 40 years. So I wrote a very tight paper. Probably still going to go a minute over, but forgive me. And for those of you that, for any number of reasons, can't see me currently on the screen, I am an almost 34-year-old cisgendered white man, beard, bunch of tattoos, all kinds of fun stuff. So hello. All right, on to the paper. Let's go. So I want to thank everybody that put on this panel. Lisa did a better job. She made a more exhaustive list than I did. So thank you, Lisa, and thank you, everybody. Thank you to the attendees also for, attending. I'm just grateful to be here, to be included. I hope that my contributions to today's conversation don't go too far down the rabbit holes of esoteric reflection or autobiographical anecdote. As my students can and probably would attest, I'm prone to tumbling down both of those, but I usually have more than a 10-minute presentation to find my way out of them. With that caution in mind, then, I feel obligated to state from the outset that I do not work in disability theology, technically. There are many others that do great research in that field, and I'll point to some of their work in a moment. My own research, as was read out a moment ago, investigates the relationship between similarity and otherness in theological accounts of personhood, highlighting the ways that oversimplifying similar or other can very easily lead to misunderstanding and marginalization. I'm also convinced that those of us working in fields like theology, really just the humanities in general, are, whether we acknowledge it or not, always doing autobiography in and through our research and teaching. This brings me to the reason that I'm speaking to you today. I have an acquired disability. I haven't publicly talked about this much, but I now feel that I need to. Why? Well, at the start of each semester, I reach the accommodations section of my syllabus. Many of you do the same, I imagine. And I use this as an opportunity to tell students, I can only see a tiny portion of the classroom at one time. If you ever have your hand up for a while and I haven't called on you, it's not because I hate you, it's because I can't see you. I go on to talk about my traumatic brain injury in 2009, which resulted in brain surgery, cerebrospinal fluid leaks, and most lastingly, severe temporal hemifield loss. I have no peripheral vision. And as often happens with vision loss of this type, my eyes can't quite work in tandem. Until there is a major breakthrough in optic nerve regeneration, therefore, I will both be partially blind and have constant double vision. I bring this up at the start of each semester for two reasons. First, on a practical level, I need to let students know about my needs in the classroom. The second reason is actually more important. I feel compelled to highlight that despite my appearing, and I will use the biggest scare quotes ever, normal, to anyone unfamiliar with craniotomy scars or the aftermath of skull fractures, I have a disability. I note that the odds are very high that in any given classroom, there are going to be students with varying needs and struggles, both physical and mental, that aren't immediately apparent. I ask students to please be considerate of each other's differences, including disabilities, whether visible or invisible, disclosed or non-disclosed. I suggest that rather than ignoring or rejecting differences, we need to learn to celebrate them, suggesting that theology should be an invitation to engage the world with greater depth and breadth, pushing back on our tendencies toward exclusionary narratives or false normativity. I have been truly shocked by the number of students that have approached me after these initial class meetings and thanked me, sometimes rather emotionally, sharing that they've never heard a faculty member say anything like this. I've even had a few students say they feel seen, then catch themselves embarrassedly because of the ironic visual metaphor, at which point I assure them that I am not offended. If anything, I laugh and the tension is alleviated. This is, in many ways, why I wanted to be involved in this panel and this year's Disability Month in general. The need for visibility, representation, naming, and maybe even alleviating real tensions in our experiences. I've long felt myself in a place of cognitive dissonance regarding my acquired disability, the role it plays in my life, and how I ought to discuss it. I tend to avoid describing myself as disabled, both because of my own desire to escape the stigmas still accompanying that word, and because I somehow don't feel disabled enough to really identify as such. I'm now nearly 15 years removed from the accident that altered my vision my freshman year of college, and I no longer really remember what it is like to see as I did before. I'm still able to go about most activities and present as normal, scare quotes again, in most social situations. At the same time, I haven't been able to drive a car in 15 years, and I'm acutely aware that I need to vaguely cross my eyes while being photographed if I want to avoid looking different than the version of quote unquote normal I internalized long before I got hurt, before I became disabled. Here, it's worth highlighting the dangers of creating a norming narrative for disability. Just as there is no perfect prototype for quote unquote normal personhood in general, there is no cookie cutter or boilerplate template for persons with disabilities. Now, because of the length of the hospitalization following my injury, I had to withdraw from my second semester of college. Until the following fall semester, all I wanted to do was get back. I wanted to get back to campus, get back to my friends, get back to the things I enjoyed doing, but all of this was symptomatic of wanting to get back to quote unquote normal. I also wanted to be seen as such. This speaks to the elephant lurking in all rooms shaped by ableism. To be disabled in an ableist society is to be othered, to be isolated. To be disabled without appearing disabled is to be isolated in the liminal. Much of the reason that I have largely avoided identifying as disabled is that my 19-year-old self didn't know any better than to not want to be known as a disabled person with all the baggage I presumably sort of projected onto that. I have spent a lot of time and money wrestling with this in therapy, and it's led to some difficult insights, not just about myself, but about why and how I want students to feel seen, to feel known, listened to, celebrated as irreducibly unique, not tokenized or stigmatized. This is true when we discuss what it is to be human, not just when we talk about accommodations. This is where things get very tricky. Accommodations are useful both in and out of the classroom, but they aren't enough. When I re-entered college after my accident, I was offered additional test-taking time and a separate room for exams. I didn't end up using these as they didn't meet any of my concrete needs. In hindsight, what I needed was something no university office could offer me. I needed societal shifts, better public transit, affordable housing, and transit pricing in cities that do have good transit systems. Frankly, I still wish for those. More nuanced reflection upon what we mean when we use the word normal. In fact, I needed to learn that no such thing as quote unquote normal actually exists. I also needed tools for reflecting upon myself as something more than a broken version of what came before or a lesser version of a person. I needed someone to teach me that disability is neither an impoverishment nor a threat to human development and flourishing. I needed mentors that offered real accompaniment, community, and collaboration, not just accommodation. I needed to be inspired to develop a society that celebrates both similarity and dissimilarity, while also recognizing the dependence and vulnerability inherent in the experiences of all human beings, not just those tacitly treated as a flaw in the system of human living. In many ways, my experiences returning to college reflected the need for broader conversions, both in myself, those around me, and in the societal systems we occupy. This is part of the reason that I believe theology must engage in conversations surrounding disability. As a theologian, I'm aware of the power religious symbols have in shaping people's lives, their horizons for meaning making, and their frameworks for understanding themselves and others. Here, I'm deeply grateful for the work of disability theologians like Catherine Karen McRae, Tom Reynolds, Mary Jo Iozio, and others, who highlight that, despite Christians' complicity in cultures of ableism, which is frequent, we and other religious traditions have storehouses to draw from when striving for a more inclusive world. We have tools for helping affect change and conversion, not in the sense of becoming a member of a religion, but in the sense of a radical reorientation of values and actions. I and the theologians I just named are part of a tradition that believes God became incarnate as a fully human person. And this incarnation is neither a rupturing nor a begrudging triage, but a drawing out of the goodness and beauty always already present in the world. This incarnation is the person Jesus of Nazareth, who explicitly identified with those othered most by unjust systems, who spoke from within his own Jewish context by echoing the Hebrew prophets' admonition of marginalization, who was brutally murdered because of the threat that he posed to dominant status quos, who Christians believe to be the Christ that assumes and redeems all, truly all, aspects of humanity, rising from the dead, still proudly bearing his wounds, inviting his disciples into often uncomfortable collaborative engagement with the unexpected reality of his corporeality. Now, don't worry, I truly am not trying to convert anyone to Christianity. I simply want to note that this way of speaking about Jesus isn't typically presented from pulpits or pamphlets. I've only rarely encountered these points expressed theologically by someone that hadn't themselves experienced a great deal of othering, a great deal of marginalization, often in multiple intersectional ways. This disconnect reflects broader cultural problems, like ignoring what we perceive as defective or challenging, and it's precisely here that theology must be liberative. Theologians must critique, for example, societal prioritization of those bodies deemed most capable of production and most easily commoditized by certain kinds of labor, by certain kinds of beauty. This has consequences for the way we speak about disability, and as my very good friend Kate McRae highlights, what we say about disability reveals deeper cultural attitudes about supposed perfection, in big scare quotes, our moral goals, etc. These statements reflect our latent images of a full human life. Doing theology in a community like Molloy, a Christian institution, I need to rise to the challenge presented by belief that all human beings equally participate in the image and likeness of our Creator. We are no less known or loved by God because of our race, gender, biological sex, sexual orientation, age, disabilities, or any other elements of our embodied personhood. God also doesn't judge us according to modern metrics for who matters or who is quote unquote normal. I needed to hear this as a 19-year-old desperately trying to adjust to life with a disability, and I still need to be reminded of it today. This is why I'm so grateful for events like this one, filled with people that deserve to recognize and celebrate their uniqueness and the uniqueness of all others. I'm really excited to see how this is going to play out in the Q&A. Thank you, and thank you, Lisa, for indulging me going slightly over time.
Actually, you were right on the money.
Well, I'm bad at timing then. Thank you for being better at it than I am.
Thank you. Thank you to all of the speakers. There are some questions that had come up from registration that I'd like to integrate. And whoever, certainly from our speakers could jump in and try to maybe address some of these. The first question that came up was, how can we transform patient care to ensure that those with disabilities feel as though their needs are being met? Dr. Spatarella, I know you had mentioned something, you had a couple of ideas as far as how to do this. Would you
Yeah.
like to elaborate on that?
Sure, sure. So I guess because of my own personal experiences, I have a lot of suggestions. I can't speak for the greater world, individuals with disabilities that are seen or unseen. But I think sometimes we have to call out the system and say it out loud, and saying, I don't feel like my needs are being met. Sometimes it's assumed that, I go into a physician's office with a problem and I come out with a prescription, I feel satisfied. And I will say that myself, personally, as a nurse practitioner, patients weren't happy unless they walked out with something. They want to receive something to validate. Yes, whatever the problem was is validated and recognized. So everybody wants to be recognized. Overhauling a health system is, I don't have a pat answer for that, but I can say that those individuals that have a disability, whether seen or unseen, do need to make others know that I'm not happy, I'm not satisfied. How can you help me? And a lot of people walk away unsatisfied and just, kind of complain.
Thank you. There was another question that came up about what advice could we give others on navigating coming out, so to speak, again and again with those invisible disabilities that you had all mentioned. Any suggestions or any discussion we would like to have on this?
I think I would say that it is a personal decision. Thinking about the greater piece, like that's a piece with the invisible disability, but just there's no one way to really say this is the way to approach it. It has to work for you. You have to understand the circumstances that you're in. It's disclosure of other marginalized identities too, like I'm just saying, but just what's the rationale for it? Yeah, obviously it's a safe space. Like all those things come into play for you, but it becomes like a personal decision. I would say one thing to consider is, are your needs being met, whatever the context it is, right? That might be a way to really get that out there, ensure that whatever context you're in, that you're whatever you need or whatever you need to do, that there's going to be supports in place for that. But again, you have to make that decision of is it safe? Unfortunately, many places aren't safe because how was built for disabled people. So I just think really taking that into context and kind of making that decision. But again, as research has shown, and just to know, there's a plethora of people on college campus that do not disclose for a myriad of reasons. Even those who may have had services in K-12, there's a large population that don't disclose when they go to college for different reasons. So yeah, it's just it's individual circumstances.
Yeah, if I might piggyback on that, I completely agree with everything Dr. Whitaker just said. Man, while you were talking, a lot of the things you were saying were really resonating with me. Everything that I am about to say will probably lean back on the exact same point, which is that I wish that therapy were more easily and readily available in the United States of America. We have a profoundly unjust healthcare system. And basically everything that I will say to all of the follow-up questions involves some element of therapy, because one experience that I've had that I would flag in relation to the fact of having to, as it was put in the question, sort of come out as disabled repeatedly, it dredges up trauma often. I joke with students when we're actually talking about Jesus of Nazareth and how he sure seemed to have a lot of baggage associated with his hometown. My guess is every time he would run into random people, they'd be like, "Aren't you the one whose mom said that God's your father?" And I bring that up because I didn't go to my 10-year high school reunion, and I try to avoid, frankly, seeing most people from high school because they will ask me, "Didn't you almost die?" And then I have to sort of run through the same pat story over and over and over. And that really hurts. Having to articulate and explain why I can't see the way that I used to at this point and probably never will again is hard. And so I think one of the elements in this conversation that really has to be drawn out is there is a trauma to that repeated coming out that we oughtn't take lightly, that I think we need to build better safe spaces for facilitating. I have to do it at the beginning of class, and I've now taken it as an occasion to make people feel more comfortable and seen. I don't think there is a one-size-fits-all solution for others, but I think we need to build spaces where it's less traumatic to deal with things like this and to relitigate any number of past traumas.
Thank you. Thank you for that great discussion. Dr. Spatarella, there is a comment in the chat that talks about, you had mentioned 15-minute visits, which we all know is a possibility when you go to see a provider, and how it doesn't really allow for time for those that may need some extra. There was a question that it kind of aligns with this in the registration group that said they'd like to hear about like insurance. Like, so we all know like those 15-minute visits, where they come from, and how do we change that? How do we go to a system that individualizes that care? Any suggestions? I know besides money, which is probably one of the big ones.
Yeah, I think probably getting past the front desk is the key. When you call to make an appointment for a visit, I mean, I think we can all attest to it, that sometimes getting past that front desk is, like breaking into Fort Knox, but, making those needs known, saying, right at the get-go, I suspect my visit today is going to be longer than your typical time span. Is it possible for you to leave an extra 15 minutes? I mean, I don't know if it'll happen. As far as insurance, I'm still fighting huge insurance claims, and I won't give in. I'm pretty stubborn. So I don't have an answer to that. I do know that, once again, being upfront and being transparent about your needs at the get-go is super important. Is it always honored? No. And then I think the key is finding the right practitioner, the one who you will find. Don't be afraid about firing your practitioner and moving on, because if your needs are not being met, there might be somebody out there that will meet them. And, I was lucky enough to find that. And it's night and day, somebody who understands where I'm coming from. And that's important.
Thank you. Dr. Whitaker, did you have your hand up? Did you have a question or a comment?
Yeah, just a comment. Thinking about the system more broadly. Excuse me. One of the things I'm just thinking about is, what if it was like dismantled, right? And understanding that, yes, there's the medical piece, but what it often does is like it focuses on that pathology, right? So you have to come in, sit and wait, have a desk, come back, and then they diagnose. But like, what does that look like if we like use more of a model that was about like a more human approach to the disabled experience? And what would that look like for patient care? It'd be more about the patient, not about the numbers of like the money that has to be paid, right? So I'm really like thinking about in our practice and stuff, is it the human approach to this, or is it just a number, 15-minute slot, like those things? So really open it up, obviously from an UDL sense. It's probably like the age-old question, because the medical system's one of the like longest and most like mechanical, but just that piece and like being disabled in that, like it's very it's like I said, it's very just like pathological, like going into that. And we need to fix you, so like you sit over there and we'll call you back when we're ready. But just that more human approach, I think, or just understanding the barriers, like the social model as well. Understanding the barriers are there for disabled people, but prioritizing them and not necessarily the system. I think that would make a world of a difference for the experiences of disabled folks.
Yeah, I have something to add to that also. I know with the population that I spoke about, individuals with IDD, waiting is not their strong suit. It truly is not. So the way I've got around that is actually I will schedule a telehealth visit first. And that way my daughter can sit there, look at the provider on the screen. It's really not aggressive. You know, there's a screen between her and the person. So that's a safe space for her. And sometimes I'll make that visit precede an in-person visit so that some of the issues can fit into that 15-minute slot because we've already discussed some of them, or the physician already had eyes on her. So that's one way I've gotten around it. Does it always work? No, but it works for certain visits, you know, like psychiatric visits and, you know, counseling visits. It works for that. Physical is not as easy to, you know, maneuver that. But the thing is, you have to find out what works for that person. You know, there's no one prescription for everybody here, everybody listening. We all know somebody with some kind of difference in abilities. Everybody knows somebody and what worked for them.
Some great points. I'm looking in the chat section here. There's a comment here about disabled folks being more vulnerable to being traumatized or re-traumatized, and about the fact that we don't have very good cultural literacy about trauma survivorship. Dr. Bajzek, you talked about people saying, hey, aren't you the guy that almost died, blah, blah, blah. And like, how do you deal with that? And why is that okay for someone to say to you? Right? Like, how do we change that? How do we mold that so that you don't have to be re-traumatized every time someone asks? Do you have any suggestions for that?
I don't think it's okay for people to say that. No, this is hard. It actually, so my good friend Andy Vink asked a question in the chat a minute ago too that connects to this in some ways. I'm trying to figure out the right way to put this. There is a fracturing of self, at the very least in my case. I can't speak to, I think one of the technical clinical definitions of trauma has to do with a lasting inability to process selfhood in relation to the event and the aftermath of the event or events. There is a fracturing of selfhood that I have certainly experienced in relation to before and after. And I think in many ways, that's something that people that you're interacting with actually themselves do, where they think about you pre and post injury, or if they're aware of that type of trauma, or pre and post violence perpetrated against you, any number of other different traumas. That took me, I'm still working with that over time in and through therapy. I think being able to talk openly about being frustrated by that is really, really helpful. Again, I have a lot of privilege because of the color of my skin, my biological sex and gender. And so there are certain situations where I feel comfortable kind of pushing back and being like, dude, I don't want to talk about that. I'm not defined by that. There are other moments where perhaps I'm a little more given to indulging that conversation. I don't have an answer for others. I know that for me, it's taken time and a whole lot of self-reflection and a lot of support from friends and family, because I have a really good series of communal support systems, which I think is also really key, that have emboldened me to be comfortable in myself as unified whole that has some whole that has some wounds to himself. That's made me more comfortable and sometimes being like, I want to talk about that, my dude. That's what works for me in some ways.
Thank you. Thanks for those insights.